Hello, this is Edward Halprin, and I am your host for webinar number 30. It's 90 Minutes, the medical magazine of the web, brought to you by New York Medical College and Touro University. We have been providing these webinars. Now, I guess we're getting into year number 4 of our program, and this is number 30. We provide both professionals and interested lay people with the latest medical information, both to improve your practice and to be an informed consumer and patient. Our theme for today's program is, Do I Need? And we've got some old friends and some new friends to join us to talk to us about topics that are currently in the news and on your minds. First, fan favorite Dr. Marissa Montecalvo is back to talk to us about whether do I need a pneumococcal pneumonia vaccine. There are a lot of them on the market. Some companies advertise them on television. Who needs a pneumococcal pneumonia vaccine? When do they need it, and which one do you need? Dr. Montecalvo is going to teach us about this complicated topic. Our next presentation is, do I need hearing aids? And if I need them, how do I get tested for them? Who tests me for them? Who am I supposed to believe? There's so many people in this marketplace. We have audiologist Greg Goldhagen with us to talk to us about this topic. The whole subject has been somewhat upended recently when one of the major manufacturers of hearing aids announced they wouldn't do business anymore with managed care insurance hearing aid providers. So we're going to learn about hearing aids and the hearing aid marketplace today. Our next topic is, do I need a prostate-specific antigen PSA test? And if I do I need the regular one or one of these newer ones? We've asked a urologist to join us, Dr. John Phillips. Dr. Phillips has a subspecialty in uro-oncology, and he's going to walk us through PSA testing, how to interpret them, and who needs them, and what to do with the information. Now, it's the summer, and it's the time when parents start thinking about sending the children back to school in the fall and sending those students who recently graduated from high school off to college. So I thought it would be a good time to talk about, what do I need to know about the transfer of medical care for my children from a pediatrician to an adult physician? And when do I need to suggest to my daughter that it's time to make her first visit to an obstetrician gynecologist? We're going to have a panel discussion about that. And we are joined by people who will be familiar to those of you who've watched many of these webinars. Dr. Tammy Hendricks from the Touro College of Osteopathic Medicine in Vallejo, California is with us. She is a pediatrician. And Dr. Karen Murray of New York Medical College, an obstetrician gynecologist, is with us to talk about this important subject that all parents have to deal with. And then our last speaker is the Dean of the New York College of Podiatric Medicine, Dr. Mike Trepel. He is back with us because it's the summer and people are going to get interested in exercising again, going outside, walking, running, playing pickleball, playing tennis. And I've asked him to talk to us about whether you need to go to a specialty shop and buy special running shoes, or whether you can just get out a good old pair of sneakers and get outside and exercise. This is a big business, athletic shoes, and thought we should have a podiatrist teach us all about it. As always, if you have any questions for any of our speakers today, please type them in the question and answer box on your computer screen, and we'll get to as many of them as possible during the question and answer part of our program. And for those of you desirous of continuing medical education, CME credit, I will appear intermittently during today's program to go over with you the details of how to file for your CME credit. Welcome back to our program. This is webinar number 30, and let's get started with our first speaker.
Good afternoon. I'm Marissa Montecalvo, and I'll be speaking on this question. Do I need a vaccine for pneumococcal pneumonia? And if so, what kind? I have no conflicts of interest to disclose. The learning objectives of this talk are to understand the current recommendations for receipt of pneumococcal vaccination and why this vaccine is important. So I'm just going to start by scrolling back to 1901 when Sir William Osler said that pneumonia is the captain of the men of death. It used to be that tuberculosis or consumption was called the captain of the men of death. But in 1901, William Osler said pneumonia will cause enough death that it is the captain. Well, pneumococcal pneumonia is the leading cause of bacterial pneumonia in adults. It's caused by this organism, Strep pneumoniae. And what I'm showing you here is a typical chest radiograph. The white is the area of infection. Pneumonia with pneumococcus usually causes what's called a lobar pneumonia. And this is a view of the organism under the microscope. And I'm showing you this because I hope you can appreciate that surrounding this organism, which is these purple double dots, you can see a halo. That halo is a capsule, which we're going to speak about is very important for vaccination. So people with pneumococcal pneumonia are sick. They present with fever, cough, shortness of breath, pain on inspiration, and they look sick. They also often don't just get pneumonia, but they get infection into their bloodstream. And what is very important with this infection is that despite the fact that it's still very susceptible to antibiotics, we have lots of drugs to choose from. Still, within the first 72 hours, 5 to 10% of adults with invasive infection, that is pneumonia and bloodstream infection, will die. So how do you get pneumonia? Well, first of all, you pick up the organism from somebody else who has it. Usually those are children, gets into the back of your throat, and usually does nothing, and you'll just lose it after weeks to months. But in certain situations, it can get into your ears or sinuses, causing local infection, or you aspirate what's in the back of your throat and it gets down into your lungs. Now, you may think you don't aspirate, you're not lying down all the time, you're not in a coma, but everyone aspirates a bit. And what happens when it gets into the lungs depends upon the capsule type of that organism, that capsule that I showed you, plus your immune system. Once in your lungs and you have pneumonia, it can then get into your bloodstream and cause other serious infections like meningitis or a septic joint. So who's at risk for pneumococcal infection? Well, first, there's age, the very young and I hate to say very old, the older population. And mortality here is the yellow line. Then there are anatomical risk factors. For local infection, certainly cochlear implants, preceding viral infection affects the anatomy of your lungs and puts you at risk. Immune risk factors, because this is a bacterial organism and it's dependent upon antibody that your body produces. Environmental factors, there's a midwinter increase, and anyone with chronic health conditions. So let's go back to the organism before we talk about vaccination. So number one, this organism has a capsule surrounding it. It's a capsule of sugars called a polysaccharide capsule. In this slide, these larger pink items are, that's the organism, but the others are white blood cells. I hope you can appreciate here that the organism is sitting outside of the white blood cells because the capsule is protecting it from being picked up by cells that fight infection. Effective killing requires antibodies to the capsule, but of note, pneumococcus has actually 97 distinct capsules that it produces. However, I guess the good news is that really just 24 of them cause almost all the disease in humans. And this is the spectrum of the numbers of the 24 capsules that cause disease. So when it comes to vaccination, what we're doing is in a vaccine, you're receiving a portion of the capsule so that your body will make an immune response to that capsule and be ready to have antibody when you get such an infection. So the first vaccine was Pneumovax. It's been around for a long time. You've probably heard of it. And that covered 23 of these 24 serotypes. The problem with Pneumovax is that it generates what's called a pure B cell response without a lot of memory associated with it. It was and is recommended for persons over the age of 65 and those at high risk of invasive infection. In 2010, beginning with children, vaccines that had both vaccination against the polysaccharide capsule and had a carrier protein with them were developed. These are called conjugate vaccines. And the purpose of the carrier protein is that it induces a memory response. The first vaccine was Prevnar 7, which was against the 7 most common serotypes that children had infection with. That then got expanded to Prevnar 13, then to a polysaccharide vaccine with 15 serotypes, and now 20. The efficacy of the conjugate vaccines against invasive disease is higher than that for Pneumovax and more long-lasting, although those studies on duration are still being done. So this just shows you the spectrum. Here's Pneumovax at the bottom, polysaccharide 23, and here's Prevnar 20, the current conjugate vaccine. What's interesting here that I want to point out is that when these conjugate vaccines were first used in a widespread manner for children, the incidence of pneumococcal infection in adults went down, even though they weren't necessarily receiving those vaccines. So it just shows the importance of vaccinating that high-risk population of young children. So what are the recommendations for adults? Well, they're dependent upon 3 factors: age, risk factors, and previous vaccine. So I'm going to begin with adults who have not received any prior pneumococcal vaccination. So now that Prevnar 20 is available, if you have not received anything previously based upon age, let's start with the over 65. It is 65 and over. It is a single dose of Prevnar 20. What it says behind the blue line is that if that's not available, then it's Prevnar 15 with Pneumovax a year later to expand that spectrum of serotypes that you have protection against. If you have underlying medical conditions, it's the same thing. It's just that it is for all ages. It's 19 to 64 and greater than or equal to 65. I'm just showing you this to give you a sense of how prior vaccine plays in. So as I just said, if you have no prior vaccine, as it says here, for none, sorry about that, it's Prevnar 20, and that is for over 65 or those 19 to 64 with chronic health conditions. If you've received previous vaccine, then it is Prevnar 20 a year later. And for persons who have received a conjugate vaccine and Pneumovax, it gets even more complicated based upon whether you have a serious immunocompromised condition or anatomical issues. So in summary, vaccination is very important for persons 65 years of age and over, and those at high risk. If you have not previously received vaccine, it's pretty easy. It's Prevnar 20 or 15 plus Pneumovax a year later if you can't get Prevnar 20. Same thing for the younger group, less than 65, who are at risk for invasive disease. And for anyone else who's had pneumococcal vaccination previously, it's complicated. It's going to be dependent upon age, risk factors, which risk factors, and what you previously received. And so it's something that really has to be gone over with your physician. I hope I've helped clarify that a bit. These are my references, and I look forward to your questions. Thank you.
Hello again, this is your host, Dr. Edward Halpern, explaining to you how to get your continuing medical education credit. For those of you desirous of getting credit, you've got two choices. You can text the code 58 and then all capitals HARM, 58 HARM. Send that text message to 828-295-1144. 828-295-1144. If you do that, you're going to get a message back quickly, which will walk you through the steps you need to take to fill out your satisfaction questionnaire and to get your CME credit. A second choice is to use that QR code scanner on your handheld device. Scan that code by pointing it at the box on the side of the screen, and that will automatically take you to the website to fill out your questionnaire and to get your CME credit. Whichever way you choose to do it, you've got 5 days to do it, because this code's going to expire on Tuesday, July 16th at 12:30 in the afternoon. So I suggest you either write the code and the phone number down, or scan the QR code, or take a photograph with your cell phone of the screen, or take a screenshot so you can be sure to get your credit. Now, as always, if you have any questions for our panelists today, please type them in the question and answer box on the bottom of the screen. We'll get to as many of them as possible during the Q&A part of our program. And now let's resume our program.
I am Greg Goldhagen. My talk today is on, do I need hearing aids? And if I do I go, where do I go for testing and recommendations? There seems to be a lot of choices for hearing aid professionals and hearing aids on the market. What do I do? I have no conflicts of interest to disclose at this point in time. I put a nice funny slide on here. I'll put this up for about 10 seconds, but I know that we have to get through with the talk. Hearing loss. There is about 48 million Americans who currently experience some degree of hearing loss. That number is supposed to increase by 30 million in the next 40 years. Hearing loss, the health risks of the hearing loss is that it can double your risk of dementia, even a mild hearing loss, while a moderate hearing loss will triple it. Employment costs, which is something that you don't think about, but untreated hearing loss will have a large problem with your employment. You're either underemployed or unemployed, and you're going to spend more in healthcare costs over a decade. The treatment delay of the hearing aids are about 10 years. Now, there are things to do to get people to go and get treated sooner than those 10 years. And one of the easiest things to do is primary care physicians, if they can ask just one question, which is just simply rate my hearing loss from 1 to 10, 10 being the best, 1 being the worst. If somebody gives you an answer of 7, of at least a 7, they need a hearing test. If they give you an answer of 6, they most likely need a hearing aid. Patients, if you have difficulty in understanding, if you have problems with understanding people when they're not looking at you, or when you're in noisy environments, you probably need to get your hearing tested. Where can you get your hearing tested? You can go online and get tested online. There are plenty of places there that you can do it. I don't completely recommend this because no one knows what their speakers are calibrated for, and therefore it's not accurate. You can go to an ENT office or a private audiology practice or a hearing aid dealer. A hearing aid dealer is not professionally trained to do medical hearing tests. They only do hearing tests for hearing aids. But if you go to an ENT office or an audiology private practice, you can get your hearing tested, and it's a medical test, so we can figure out what's wrong with your hearing and where to go to next. The types of hearing losses that you have, there are 3 different types. You can have a conductive hearing loss. That is a hearing loss that is in the ear because of a blockage, or you can have a sensory neural hearing loss. A sensory neural hearing loss is due to the cochlear in the inner ear. It is the way it affects the way that the ear changes sound from vibrations to neural electrical impulses. There is no medical cure for sensory neural hearing loss. The medical treatment for that is to get a hearing aid, and it is the most common in adults. You can also have a mixed hearing loss. A mixed hearing loss is a combination of a conductive hearing loss and a sensory neural hearing loss, and there might be some medical treatment for the conductive and for the mixed hearing loss, so see an ENT. What to expect if you are getting hearing aids. Hearing aids are not like glasses. You are not going to get a hearing aid and hear 20/20 again. It is just not possible. The problems with eyes are usually focal point, and it's very easy to fix that with glasses. The optic nerve is usually fine. With hearing aids, the problem is with the auditory nerve. And the object of getting a hearing aid is to make speech clearer. The byproduct of this is we make things louder. Now, the perfect hearing aid will make things clearer, but not louder. Unfortunately, the perfect hearing aid does not exist at this point in time. Now, there is a new class of hearing aid that is out at this point in time. It's over-the-counter hearing aids. There are two different types of hearing aids. There are preset, which I don't think are really worth getting. And then there are self-fitting hearing aids, which usually come with an app that you can set the hearing aids. The problem with these hearing aids is they are only for mild hearing loss. So if your hearing loss is to a larger degree, they're not going to be loud enough. They're not going to be strong enough to really help you. And they are also less sophisticated and have less computing power, so they don't do as well in noisy environments or complex situations. If you are getting a hearing aid in New York, you need a medical waiver from an MD. There is the possibility that you can sign a medical waiver that says that you have been told that you should see a doctor, but you don't want to. Where to get hearing aids? You can get hearing aids in a number of different places. You can get hearing aids in a box store. You can get them from a hearing aid manufacturer storefront like a Miracle Ear or a Beltone. You can get them from internet sellers or an ENT practice or audiologist. Box stores are nice because they do sell things cheaper, but the continuity of care is going to be less because the turnover in personnel happens to be quicker. The audiology manufacturer stores, they only sell one type of hearing aid. And in my opinion, not every hearing aid makes a hearing aid for every hearing loss the best. So if you can go to somebody who sells multiple different brands of hearing aids, you're probably better off. You can go to an internet seller like Yes Hearing or Lively. The problem with them is you're doing everything through Zoom, and it's definitely less personal. You can go to an ENT practice or an audiology practice. Most of the time, all the time, the audiologist is going to be fitting the hearing aid on you. And that is good because they are trained to fit the hearing aid, and you develop a personal relationship with the person who's fitting your hearing aid. You want continuity of care. You want to make sure that you develop a relationship with the person who's fitting your hearing aid. The biggest blocks to getting a hearing aid at this point in time is that you have cost. Hearing aids are not cheap. The cosmetics, you have people who they don't want them to make them feel old, denial that there's a problem, hassle of just doing things, and a resistance to change. Cost is always one of the major factors, but it is interesting that when you go to countries that have socialized medicine like France and England, that the hearing aids are not usually that much over 25%. They're usually 30 or 35%. And cost, I don't think, is as big a factor as people say that it is, but it is something that is the most mentioned factor. Hearing aids have improved over the years. Their performance in noise is much better than what they have been in the past. The cosmetics are better also. Even hearing aids that you think that go behind the ear They're hidden by the ear. You don't see them as much. Cosmetically, people are not going to notice the hearing aids. It is important, and I do have to stress this a lot. You have to have a comfort level with the person who's fitting your hearing aid because it is a long-lasting relationship. There is a prescriptive method of fitting a hearing aid, but everybody's ears are different. You have to be able to be comfortable to complain about problems with your hearing because there is the art of fitting a hearing aid. There's the science of fitting a hearing aid and the art of fitting a hearing aid. You have to be able to come in and discuss what your issues are with the hearing so that the right adjustments can be made so that they can help you more. The one thing that I hope you take from this is if you are going to do things, hearing aids are not perfect, but never let the idea of perfect stop you from doing better. Hearing aids can help you. It will help you in terms of your health care, in terms of your mental health, and even your financial stability. So taking care of your hearing is something that I believe is very important. Thank you very much.
Hello, my name is Dr. John Phillips. I'm a urologic oncologist here at New York Medical College. One of my primary focuses is on the management of men who have prostate cancer. And prostate cancer is the #2 solid malignancy in men. And so therefore, testing for its diagnosis is a pretty relevant thing for most American men. The #1 way it is diagnosed is with prostate-specific antigen screening, or PSA screening. However, it is not without its controversies, and I wish to discuss those controversies and present some of our national guidelines. I have no conflicts of interest to disclose. Importantly, prostate cancer had been discovered many, many decades before PSA was even discovered. But even then, surgeons like Dr. Hunter McGuire in 1895 said that cancer of the prostate, although rare, is probably more common than statistics indicate, but that any operation to be of value must be done early and radically to be of any benefit. For many, many years, there was no way to detect prostate cancer early enough. Prostate acid phosphatase and alkaline phosphatase did exist in the 1950s, but these were almost only elevated when patients had metastatic disease. PSA itself, again, prostate-specific antigen, was discovered in the early 1980s by Dr. Wang and colleagues at Roswell Park. One of the problems with PSA testing is that many men who have no prostate cancer may have an elevated PSA, and many men with prostate cancer may have a normal PSA. This is a diagram of 2 Gaussian or bell curves showing men who underwent prostate biopsy. The blue curve represents those men who have no prostate cancer, and the red curve represents men who did have prostate cancer. You can see here they overlap significantly. That is, that some men who have prostate cancer have a PSA that is in the normal range of 4 or less, and some men who have no prostate cancer have a PSA of 4 or greater. It is our job as urologists to sort of filter out these patients to perhaps avoid unnecessary prostate biopsies in men with no prostate cancer and perform prostate biopsy in men at risk for life-threatening prostate cancer, even if their PSA is normal. Nowadays, the majority of men are diagnosed with prostate cancer when it is an early stage. And this is largely due to the fact that PSA finds prostate cancer in 48% of men. Another group of men have prostate cancer identified as part of a surgical procedure for benign disease. You can see here, therefore, that many men are diagnosed when the cancer has not spread. Over time, you can see the benefits of PSA screening on the American population at large. In 1992, PSA screening really was in full force, and you can see here that the incidence of prostate cancer peaked around that time and started to come down in a steady fashion. However, death from prostate cancer did begin to trail off here, and this was thought to be due to either PSA screening itself or the effects of having men come in to see their urologists earlier and enter healthcare at an earlier age, and perhaps stave off the effects of prostate cancer before it can metastasize. There were 2 very important clinical trials that looked at whether PSA screening had any value. One was the Prostate, Lung, colorectal and ovarian cancer trial, or PLCO, and one was the European trial, also known as ERSCPC. The PLCO trial unfortunately felt that there was no benefit overall for PSA screening in saving lives. The European trial felt, however, there was a modest benefit if one waited long enough after the PSA screening took place. However, both of these trials were very flawed. First of all, in the PLCO trial, many men who were not supposed to have screening PSA tests did in fact have PSA screening tests, even up to 80% of the control group, while the European trial needed to screen many men, almost 1,400 men, to benefit the PSA screening can save a single life, and that one needed to treat almost 50 men with either radical surgery or radiation therapy to benefit the life of one person, compared to, say, 10 people who underwent breast cancer therapy to benefit one woman. The European trial also required many years of follow-up. The United States Preventative Services Task Force quoted these two failed trials to give a very low grade to PSA screening. And they felt that based on this work, they felt that the harms of prostate cancer specific screening outweighed the benefits and gave it a D. That there was moderate or high certainty that the service has no benefit, but that the harms outweigh the benefits. The American Urology Association responded by saying that those recommendations were based on flawed studies and emphasizes the fact that shared decision-making with the patient was very important for the patient to help decide whether PSA screening should be done. And the task force did not address high-risk groups, including African-American men who may have an up to twofold increased risk of prostate cancer and men with a family history. Our guidelines therefore recommend against screening men who are younger than the age of 40, or in men 40 to 54 who are at average risk of prostate cancer, or in men who are greater than 70 years of age or have fewer than 10 years of life expectancy. However, we do recommend PSA screening in men who undergo shared decision-making, especially in the ages of 55 to 69, and in men from African-American families or in families with first-degree relatives. We also recommend screening every 2 years, perhaps to increase the benefit without weighing harms. There are other ways to check for prostate cancer, including total PSA and free PSA, PSA kinetics, velocity, volatility, doubling time, even PSA density, as well as other forms of PSA in the blood and in the urine. And some of these tests can be used as part of that shared decision-making. We also use MRI of the prostate in that shared decision-making to stratify patients for low and high risk, and to incorporate these other tests, especially fusion-based tests, to allow us to identify men who may not need a biopsy at all. Some men who have prostate cancer can even be followed with active surveillance and do not need treatment, and under careful guidance may avoid the harms of treatment and enjoy the benefits of surveillance. We use genetic tests as well. Decipher and Prolaris, the two most common genetic tests to help the DNA of the cancer itself help make our decisions. And some men who undergo therapy for prostate cancer may only require the small part of the prostate with the cancer to be treated, avoiding the morbidity of more extensive therapy. Thus ends this short talk on PSA screening, and we are very happy to discuss with patients and their family the benefits of PSA screening and perhaps methods to tailor to the patient's own needs to identify those who are truly at risk for prostate cancer and those who are not. Thank you very much.
Hello again, this is your host, Dr. Edward Halprin, telling you how you can give back to New York Medical College, because programs like the one you're watching and listening to today and the research which underpins what we're talking about today all take time and effort and money. You'll notice we never charge for the CME credit, for example, for these programs, but there are real costs to creating these programs. We hope you'll consider making a tax-deductible gift to offset our costs. Great things are happening at New York Medical College and at Touro University. We hope you'll want to be a part of it. There are 3 ways to make a donation to support webinars like the one you're watching now. You can phone 914-594-29 2720. And a friendly, happy person at the Development Fundraising Office will be more than happy to take your information and your credit card information to make a donation. If you'd like to do it online, go to the website www.nymc.edu/give, and you can make the donation online. And if you are a believer in checkbooks and pens, like me, you can make your check payable to New York Medical College, write in the memo line support of the webinars, and put it in an envelope with a stamp and send it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. We do want to thank you in advance for thinking of us and supporting these programs. Stay safe and healthy. If you have any questions for any of our panelists, please type them in the Q&A box on the screen, and we'll get to as many of them as we can during the Q&A part of our program. And now let's get back to our program. Hello again, this is your host, Dr. Edward Halprin. And now I'm here as your moderator for a panel discussion. As you detected, our theme for today's webinar is, do I need to? We have speakers about, do I need special running shoes? Do I need hearing aids? Do I need the pneumococcal pneumonia vaccine? Well, our topic now is, when, as a parent, do I need to help my teenager or young adult child make a transition from getting their medical care from a pediatrician to an internist, a family medicine physician, an obstetrician, gynecologist? It's a common problem. We have a few specific aspects of this we want to address, and we have two veterans of our webinars to talk with us about the topic. I'm going to ask them to introduce themselves to you in alphabetical order, I suppose. We'll start with Dr. Hendricks.
Thank you so much. My name is Dr. Tammy Hendricks. I am a pediatrician. I'm also the Dean and the Chief Academic Officer of Touro University, California College of Osteopathic Medicine. Great to be here.
Dr. Murray.
Thank you for inviting me, Dr. Halprin. My name is Karen Murray. I am an obstetrician gynecologist, and I am the Dean of Admissions for New York Medical College School of Medicine.
Well, thank you both for joining me. Let's start with some common questions. Dr. Murray, when's a time for a teenage girl to go have the first visit with an obstetrician, gynecologist? Parents will ask, is it when menstrual periods start? Is it later? When's the right time for the first visit? And what should a parent and a teenager expect from that first visit?
Thank you. So that's actually a very common question. I get that question often. The American College of OBGYN actually have a recommendation that they have out, and it's really between the ages of 13 and 15. Most young girls get their menses between the ages of 12 and 14. And so 13 to 15 is a time that's recommended for young ladies to come in for their first visit. During that first visit, it's usually just a conversation. It's a transition from their pediatrician to their gynecologist. And it really is recommended that they come in with lots of questions that they may want to have answered. Questions about, puberty, questions about their menstrual cycle. When they come into the gynecologist, we'll have specific questions that we'll ask them about whether or not they're sexually active, they're in a serious relationship. And the first visit usually does not entail a physical exam. It's really more of a conversation, information gathering, and answering most of the questions that the young lady and her parent may have at that time.
Dr. Murray, if a parent says, do I go to a general OBGYN or am I looking for someone with specialty certification in pediatric adolescent OBGYN? How would you advise them?
There are pediatric gynecologists out there. However, most general gynecologists have enough background to take care of a teenage patient. Many offices can accommodate and will accommodate teenage patients. So there really isn't a need to specifically go to a pediatric gynecologist. Now that, of course, is up to the parent and you know what they would like to do, but it's not really required or recommended.
Thank you. Dr. Hendricks, let's say the mother's there with you in your office discussing a teenage girl going to the obstetrician gynecologist. And the mother says, now, wait a minute. If we do that, are they going to send me out of the room and start having conversations without me participating? I've always been in the room when we've talked about my daughter's health care. Are we getting to that stage where I'm going to be told to go sit outside? I'm not sure I feel comfortable with that. What would you advise, Mom?
Yeah, that's a great question. And if they're one of my patients, they're probably already used to having a little bit of time out of the room. You know, I think this entire topic is really focused on that. It's the transition of the child to the autonomous adult, and how do we help our teenagers really make that transition so that they can start to have more say in their healthcare and really start to participate in their healthcare as the young adults that they are. In my practice, starting around the age of 12, there is always a time in the history where I'm asking the parents to step out of the room so that I can speak with the child on their own. And so I would certainly, in this instance, let the mother know that yes, there's likely going to be a time where the gynecologist will ask you to step out of the room so they can speak to your child on their own. And that's a really great thing. And you should encourage your child to be able to have those conversations and start to develop those really important relationships with their healthcare clinicians, so that they can have that trust level and start to take a good active role in their own health.
Thank you. Let me ask both of you to talk about another aspect of this issue. There are several published studies about gender preference by adult patients in regarding picking an OBGYN doctor, a breast surgeon, or even someone to do a colonoscopy. Skill level being equal, would you prefer a male or female? Reproducibly, about 50% of American women say, I'm indifferent as long as their skill levels are equal. About 40% of American women say I prefer a woman. About 10% say I prefer a male. So if mom or the young woman say to you, well, how do I pick? And do I get to express a preference for a male or a female OBGYN? How would you advise them? Let's start with Dr. Murray first and then go to Dr. Hendricks.
Thank you for the question, Dr. Halperin. I think it really comes down to the patient's comfortability. Many young girls are at different phases and parts of their developments, regardless of their age. And so if your young daughter is someone who's comfortable having conversations with a physician who's a male, a lot of times if they're coming from a male pediatrician, they're pretty comfortable having conversations with another male. The first visit is just a conversation. So they may be able to come in and just have a conversation and see how comfortable they feel with that particular physician. Then there are other females who would prefer to have another female, and moms would prefer them to have a female. And so again, I say it's really going to come down to that first visit, that first conversation, seeing how comfortable you are with that physician, and then taking it from there. The expectation is not to have a physical exam on the first visit. So it gives you an opportunity to get to know the physician, get comfortable with them. And, you know, the first visit is a lengthy visit, but it's just a discussion.
Dr. Hendricks?
Yeah, I completely agree with that. I would encourage them to go to that first visit with an open mind and not have an expectation, that they're kind of putting on the physician based on their gender. I typically will share, my own personal experiences of having really great experiences with male gynecologists, so I would encourage them to enter into it with an open mind and certainly know that they can always choose to see a different physician if there isn't a good match for them after that first visit.
Thank you. Let's turn to a different topic. Whether the teenager or young adult is male or female or whatever their gender identity is, when's the time to stop getting your general medical care from the pediatrician? It's time to go see an internist or a family medicine doc, Dr. Hendricks. When do you advise? Is this an issue while you're in high school, when you are off to college, when you come home from college? For young people, the only thing most of them ever know about medicine is their pediatrician. This is a big transition for some folks.
Yeah, absolutely. That's a great question. And it is a big transition. We have the opportunity to get to know these children very, very well from the time often that they're born, and they see us many times in those early childhood years, all the way through adolescence, which is a really wonderful opportunity to be able to build that rapport and build those strong relationships with our teenage patients. I often find that the majority of my teenage patients are scared to go and see somebody else because they're leaving the safety of this pediatric office. I typically start having the conversations with the families around age 15 or 16. We tend to start seeing the kids less frequently as they get older. And so oftentimes, if I haven't laid that groundwork around age 16, suggesting that they may want to start thinking about transitioning to an adult healthcare clinician, that, by the time they're 18, which is our office's cutoff for when they can see the pediatrician, then it's suddenly a surprise. And that's never something that we want to do to them. So typically having those conversations, I will say there are specific instances where I will see kids much further into adulthood, so into their early 20s, sometimes even mid 20s. Oftentimes those are children or individuals who have special needs, who maybe adult healthcare providers aren't as familiar with taking care of those individuals. Maybe there's certain reasons why it's better, safer for them to be in the pediatric office environment. So in individual cases, we will often see them a little bit older, but I would say most pediatric offices go to either age 18 or age 20, 21.
Thank you. Let's just finish up with one last question for Dr. Hendricks. It's summertime, and we're going to have some people watching this webinar who are about to send the recent high school graduate off to college. What would one expect from your pediatrician's office for transferring medical information to the student health service at college? Maybe it's more than just routine visits. Maybe they have a child who's diabetic, asthmatic, has other medical issues, and mom and dad are a little worried that if they don't feel well 3 weeks into their freshman year, they're going to go walk into some student health center at Mega State University, and that beloved pediatrician isn't going to be there to take care of them. What would you advise about transfer of medical records to the student health center?
Yeah, that's a great question. Certainly informing, educating the family about doing those release forms. So signing release forms even ahead of time before the child goes to the campus, so that we can directly transfer the medical records to the healthcare facility that the child will be, or the young adult will be going to. I have often written pretty detailed letters for my patients that I'll give to my patients specifically policy that will outline each of their medical conditions, what medication they're on. Maybe I'll even provide a little bit of history regarding surgeries or procedures they've had or things they've tried that didn't work for them. So that's something they can actually keep with them themselves, something they can refer to as they're speaking to their, future healthcare clinicians. Things like that can be very helpful. And then once again, this is a great time to remind parents that we need to empower the young adult in the room to start taking care of themselves. It's a very big transition and important to have many of those conversations.
Thank you. I want to thank Dr. Murray and Dr. Hendricks for joining me for this panel discussion. If you have questions for our panelists or for anyone at today's webinar, type them into the question box on your screen and we'll get to as many of them as possible during the question and answer period of today's webinar. Thanks for sticking with us, and let's move on to our next topic.
Good day. I'm Dr. Mike Treppel from the New York College of Podiatric Medicine, and the question that I have been posed to answer today is, do I need to go to a specialty shop to buy running shoes or shoes for sports? Aren't regular sneakers good enough? For this talk, I have no disclosures to make. And the answer is no, you don't need to go to a specialty shop. If we look at where people are buying their shoes these days, it is mostly in department stores, some specialty footwear stores, outlets, branded stores, or other places that they can look at. The post-pandemic, the movement from in-store to online purchasing has been significant, as it is in most other purchasing types. And in fact, if one looks at an outcome study or meta-analysis regarding the role of injury prevention when prescribed running shoes are contrasted against non-prescribing shoes, it shows that there really isn't much of a difference. So for the average runner without any significant problem, they can generally go and purchase their own shoes from whatever outlet that they feel most comfortable doing. And this is big business. The average runner spends anywhere from $100+ for a specific pair of shoes, and serious runners can spend upwards of $400 a year on purchasing shoes. And the market as a whole is quite significant. In 2023, the market size was approximately $12.3 billion with a compound annual growth rate of 5.7. We're looking at $17 billion by 2032. So a lot of money is spent on running shoes. The purpose of the running shoe is to support the foot and recognize that we have evolved from a grasping foot to a foot that requires not only propulsion, but shock absorption as well. We have evolved from a prehensile foot to one which supports bipedal locomotion and ability to ambulate in an upright position, which allows us to free up our hands for other purposes. The history of running shoes is quite long. When I was a kid, we all went down and got Keds or Converse shoes, and there was one model, and you had a choice of a black or a white shoe, and that was virtually it. As the years went by, we see a transmission and certainly design and materials, colors, etc. And just because something is new doesn't necessarily mean it's better. As Coca-Cola found out several years ago, the new Coke was a disaster and has no improvement over the Coke Classic. Running shoes really got a boost in the mid-70s by the running doctor, Dr. George Sheehan, cardiologist working with a podiatrist, Dr. Dick Schuster, and people started to become more aware of what type of shoes and orthotics they were utilizing to propel it. So where can you go to get running shoes? Well, you got the specialty stores, New Balance, Nike, Asics, etc. You can be sure that if you're to go into one of those stores, if you go into a Nike store, you're going to come out with a pair of Nike shoes. The specialty athletic stores like Foot Locker or Dick's supposedly have people that are better trained to look at a foot and to recommend a specific type. But again, they generally have marginal training. Specialty shoe stores, and there are many, generally will have a pedorthist who's available, and they can give better advice as to the shoe type. course, online shopping is paramount, and many people will just go to that and look up advice online. Some of these specialty stores will do foot scanning. These are not generally very helpful, as they're two-dimensional, not three-dimensional, and they're static and not dynamic in nature. So when one walks into the store, they've got multiple different shoes. What are the considerations that you take into account when purchasing a shoe? Well, number one, what are you going to do? Walk, jog, or run? Running shoes very generally need to be lighter in weight because you're going to be going faster and generally for more distance. Likewise, distance, if you're going to go through a marathon, you want a light shoe. Generally, marathons are on flat surfaces, so you don't need quite as much support. As opposed to plodding through a trail or walking through or race walking through a park on a flat surface, the lightweight shoe is as much needed. The terrain, a flat surface running, you don't need as much medial lateral and dorsal stability as opposed to trail running. This foot type is also terribly important. A flat hypermobile foot, as you see on the left, is going to require more support. A cavus foot on the bottom there is a very inflexible foot and is going to need much more shock absorption and padding. On the upper right, the equinus foot is going to require a heel lift, and where you have forefoot deformities, you're going to need the toe box deep enough to accommodate the foot. So the anatomy of the shoe can accomplish many things: comfort, prevent injury, distribution of weight, shock absorption, propulsion, support, and realignment. Key features that are critically important. If nothing else, the forefoot has to be flexible. A rigid forefoot impedes forward progress, precedes plantar fasciitis, shin splints, and posterior tibial tendonitis. Medial and upper stability is important when you're running on trails or uneven terrain. This is a good type of shoe for the average runner. Stack height is defined as the distance between the foot and the ground surface. The minimalist shoes have very little padding on the bottom. You can, it's like walking directly on the ground. On the other extreme, maximalist shoes, you can hardly feel the ground at all, and you just feel the shoe. The so-called platform shoes that were in vogue several years ago precipitated an inordinate amount of ankle injuries due to lack of proprioception. Heel drop is the distance between the toe and the heel. Zero drop shoes or negative heel shoes will prevent a midfoot or a heel strike. They generally will do a forefoot strike, and these will precipitate forefoot injuries and added metatarsalgia. The trend between minimalist and maximalist shoes, you have proponents on either side. The minimalists say tout the added proprioception that one would get and makes the muscles of the lower leg work harder and strengthens them. On the other hand, the maximalist shoes like the Hokas have increased platform, they have increased stack length and decreased proprioception. On either side is, except in specialized cases, probably be avoided. I prefer more of a terrain type shoe that has at least a 6 millimeter heel drop and an average stack height. In the 2023 marathon, the shoes that ruled here were, these are world-class runners, were pretty much the Adidas, Nikes, and ASIC type shoes. The type shoes that I tend to recommend for the average type runner would be the Brooks, Saucony. I like New Balance a lot, and ASICs do very well as for the average runner. So with these parameters in mind, the average person should be able to go for whatever venue that they like and be able to purchase a shoe which will fit their needs. Thank you very much for the opportunity to address this topic.
Hello again, this is your host, Dr. Edward Halprin, explaining to you how to get your continuing medical education credit. For those of you desirous of getting credit, you've got two choices. You can text the code 58 and then all capitals HARM, 58 HARM. Send that text message to 828-295-1144. 828-295-1144. If you do that, you're going to get a message back quickly, which will walk you through the steps you need to take to fill out your satisfaction questionnaire and to get your CME credit. A second choice is to use that QR code scanner on your handheld device. Scan that code by pointing it at the box on the side of the screen, and that will automatically take you to the website to fill out your questionnaire and to get your CME credit. Whichever way you choose to do it, you've got 5 days to do it, because this code's going to expire on Tuesday, July 16th at 12:30 in the afternoon. So I suggest you either write the code and the phone number down, or scan the QR code, or take a photograph with your cell phone of the screen, or take a screenshot so you can be sure to get your credit. Now, as always, if you have any questions for our panelists today, please type them in the question and answer box on the bottom of the screen. We'll get to as many of them as possible during the Q&A part of our program. And now let's resume our program. And we've got some questions for our speakers today. And let's start this afternoon with some questions for Dr. Montecalvo. If I could ask her to join us. Well, Dr. Montecalvo, as we've learned from previous webinars, there are people who want to push and probe and nuance you about your recommendations about vaccines. Our first question is, there's an increasingly long list of vaccines that adults are getting recommended to have nowadays. Can you get this pneumococcal vaccine at the same sitting with some of the other ones that have been recommended, or does it need to be done separately? We just saw an announcement that it's going to be probably time for another COVID vaccine this season and a flu vaccine. And how many times we need to get stuck on how many separate visits, Marissa?
Well, so there are data that having it at the same time as an influenza vaccine is fine. And that's really all that I think has been studied. In general, people feel that it's fine to do vaccines at the same time that are, these kinds of vaccines that are not live vaccines. But it's only been studied with influenza. So I think you could, this fall, you could probably get away with flu with something else. That's one stick, or it's 2 sticks, but 1 session, and then do your other vaccine at another time.
Okay. We've had a couple of questions, Marissa, about people with autoimmune disease. The questions relate to someone with ulcerative colitis and whether they should get the pneumococcal vaccine, and if so, should they be getting it earlier than the average person, later than the average person? Not at all, but let's cast the net a little more widely. The only autoimmune disease, of course, is not ulcerative colitis. We've probably got people listening who are interested in people with multiple sclerosis, lupus, rheumatoid arthritis, etc. What's the role of this vaccine in people with autoimmune disease?
Yeah, so it's quite safe, and I think, and the pneumococcal vaccines, and I believe that it would be recommended for persons with autoimmune diseases who are young, are between starting at the age of 19, in that persons with autoimmune disease are frequently receiving some level of immune suppression. And it's the immune suppression that is driving the recommendation for pneumococcal vaccine.
Okay. Well, we've got a lot more for you, Marissa, but we're going to do this in bite-sized doses here, not all at once. So we'll give you a break and we'll ask Mr. Goldhagen to join us. Our there, where are you? There you are. Our first question concerns parsing the distinction among audiologists. Some of them have master's degrees, some of them have doctoral degrees. Does the potential wearer of hearing aids care?
Well-
What kind of terminal degree the audiologist has? How closely should they be looking?
Audiology changed their degree in 2007 that went from a master's degree into a doctoral degree. So any audiologist, and myself is included in this, I don't have a doctorate, I just have an MS. Any person who has only an MS in audiology has been practicing from at least 2007. You know, a lot of my colleagues did go back and get the AUD degree. Some of us haven't. I think in the group that I work in now, there's 7 of us. 5 of us have the AUD, 2 of us don't. In terms of should you be looking for it or not, there's something to be said about experience. And somebody who's been working in the field for a long time, and most of the time they have the knowledge and the education and just have kept up with everything, but maybe not have gone back for the AUD and the AUD audiologist. So I myself, not having gotten an AUD, don't think it's that important or that significant, but it does show a level of dedication to have the AUD degree. But I don't think it's 100% necessary. Thank you for the question.
Thank you. Well, stick with me. We've got a very pragmatic listener here who says basically, wait a minute, before I go to anybody, shouldn't my first phone call be to the insurance company to find out what they're going to pay for this, who's in network, who's out of network, whether they're going to say you're going for a quote managed care hearing aid provider. These are pretty expensive little gizmos. The questioner wants to know, if I go see anybody, shouldn't I have a dance card with the insurance company tell me what they're paying for?
By all means, always knowing what your insurance is going to do is helpful in going in. Most of the time, any place that you're going to is going to check your insurance before you're there, so that they will know what your coverage is at a particular office. Having what your care is wonderful. I mean, and checking with your insurance company is good. Now, some of the times, and there's some information about this with the managed care, some of the coverage is not quite as good as other of the coverage, and we've seen people who have gone outside of their network to get hearing aids, because as I was talking in the talk that I gave, one of the most important things to have is a good relationship with any medical care provider, but with your audiologist especially, because there are adjustments and there are changes that are going to need to be made, that are going to be made on your personal problems that you come up with. Some of the times these managed care or your insurance is not going to cover for the person who you're most comfortable with, but knowing that is always a good idea. It's a very interesting question, and thank you.
All right, let's stick with this. Some people say the American hearing aid consumer was rocked by a letter that the Danish company Oticon sent in February saying, nuts to managed care. You want to write us a check for our hearing aids, we'll be happy to cash it, but we're not interested in doing business with any managed care providers. Now, Oticon's new brand of hearing aids are pretty expensive. We're talking about perhaps dropping $5,000 to $7,000 on them. So talk to us, please, about who's in and who's out of the market of managed care hearing aids with insurance companies.
Well, now the managed care question about that. First of all, Oticon isn't completely out. What they basically said was they're not going to use their latest technology in managed care at this point in time. And I think part of it was a financial decision, but part of it also, Oticon as a company has actually a very good relationship with audiologists. And the managed care model that was being used in a lot of this was something where it was just a mail order thing. Give us your hearing test. We're going to send you back a hearing aid without any real follow-up or without any real care to it. And Oticon backed out of that because they felt that their hearing aid was not being fit correctly and not being used correctly. And it was looked down. It was hurting them as hurting hearing aids as an industry. And they don't like the model of what United Healthcare was doing. It wasn't necessarily that they wanted to not to do that. So there are many health insurances that will pay for hearing aids that Oticon will, we can use it because there is the personal care that goes along with that. So most manufacturers have not followed through with what Oticon has done, but I would not be surprised. A lot of these manufacturers will not provide their high-end hearing aids through just a mail order place. So it's a very interesting topic at this point in time.
While you're talking, one of our listeners has been furiously typing in questions. Let's talk about going to the big box stores. Last I looked, the largest single vendor of hearing aids, not manufacturers, but dispensers, was Costco. What's the story about whether Costco's hearing aids are, quote, locked? And if you try to get them serviced by anybody other than Costco, they're going to say, can't help you. Whereas with other hearing aids, you can change audiologists and they can open up their computer and start tuning them up, but Costco can't. Is that true?
To a certain extent, it's very true. There are certain manufacturers and certain hearing aids that they sell under their own name brand that you can definitely not go to anybody else to take care of the hearing aid. Some of the brands can be unlocked. And what Costco does they ask for a large discount from the manufacturer, and they usually take one or two of the add-ons off of their units. They do that with their televisions, they do that with their hearing aids, they do that with most of their electronics, and that does cause some problems where with some manufacturers the hearing aids are locked and we cannot take care of them.
Yeah. Well, thank you. Let's give you a rest. Well, let's go to the other end of the human body. Dr. Phillips, if you could join us. There you are. Dr. Phillips,
yes.
We got some feisty questions for you, Doctor. When you quoted the American Urological Association guidelines that dispute the recommendation to reduce the use of PSA, isn't the AUA just defending the income of urologists by promoting a test that may not be necessary? This is a question you're saying, sort of take that, right?
Right. No, this is a great question. That's why it's so controversial, but what we're interested in is saving lives. And there are some men who are really at risk of dying of prostate cancer. And if we could identify those men earlier and treat them earlier, they may be able to not only be cured of prostate cancer, but avoid the complications and side effects of prostate cancer treatment. So to do so, we need some tests. We need some test that sort of gets us in the room to have a discussion with patient, see if they are elevated risks for prostate cancer, and then go from there. So, we spend most of our day in the office not scheduling prostate biopsies, but actually determining if a patient is at low risk, that they can be just merely watched, or if someone is at higher risk and may in fact need to have further studying done. And these men almost always are involved in a discussion about family history, first-degree relatives, brothers, uncles, father. and a lot of men undergo secondary testing to determine if they have persistently high PSA. Sometimes we even use non-PSA based tests like a urinary exosome test. And of course, MRI has really allowed imaging to help us see the prostate tissue and not just depend on a blood test to determine if a patient needs a prostate biopsy. So I think that the discussion has really matured if you compared to 10 years ago, that the patients were involved in this decision making, and we can really identify those men that really don't need any further testing versus those men who really need a second look. So it was a great question, and we debate about it in our own circles.
Speaking of the MRI that you just mentioned, what's the role anymore of an endorectal coil to get good imaging of the prostate, or are the magnets strong enough that that's no longer necessary?
Dr. Halpern, you probably would be able to teach me more about that. But from my basic thinking is that the coil was intended to boost the signal of the magnet. And in those days, they measured the magnet in Tesla. And a lot of those magnets were 1.5 Tesla. Most magnets these days are 3 Tesla. There may be even stronger ones. And they don't really need that onerous placement of an endorectal coil. It was one thing to try to convince a patient to get into an MRI machine. Is another thing to have them have an endorectal coil. So these days, most patients don't need to have that. Most places have a standard 3 Tesla or 3T MRI. And usually, amazing images can be obtained, within a 45 to 1 hour study. And someone had asked the question whether or not the MRI really precludes people who have minimal income to obtain the study. And that may have been the case 10, 15 years ago, but these days it's a Medicare approved study. It's known to be an important study to determine if somebody can avoid invasive, potentially risky biopsies. And we can usually get an MRI pre-approved in people who have any kind of Medicare and even managed Medicaid.
Okay. Tell us a little more about these additional tests. There was a lead article in the Journal of the American Medical Association about a month ago describing PSA with kallikrein testing and saying that if you do that plus add in an MRI, you may be able to hone in on who actually needs the biopsy. What's your view on that?
Yeah, it's true. It's a great question, and it asks, what is PSA? And unfortunately, none of these tests are pregnancy tests. They don't have a yes or no answer. They're all basically probability assessments, giving people the idea that they're at higher, average, or lower risk of significant prostate cancer. And PSA is an enzyme that's in the ejaculate. It's in the seminal fluid, and it's intended to optimize fertilization. So short of that, just picking it up in the blood is a pure accident. It's related to other enzymes which are found in Neanderthal DNA. So it's been around a long, long time, and all mammals make this. It's known as a kallikrein, and there are several kallikreins. And there is a test out there that looks at 4 kallikreins, and it's called a 4K test. The idea being that the statistical power of this test is better than PSA alone. And it was found that, a captive population of 12,000 Swedish men, if they had a 4K score or test result at a level of 7 or lower, their odds of dying of prostate cancer were almost 0. And so this test has become very popular in the US. It's called a 4K score. It's still a blood test. It's still based on PSA. And so people are looking for other things that are not based on PSA. And there's some other companies that market these. And so it's very controversial. What's in the patient's best interest, what is economically feasible, and which results can you make the most sense of? And that's part of our discussions with patients, trying to come to a shared decision.
Thank you. This important and difficult questions. Thank you, Dr. Phillips. Let's put Dr. Trepel on the stand next. Michael, the questionnaire is describing an article they read in the New Yorker magazine about a person watching the New York Marathon and someone goes running by with a T-shirt saying, Dr. So-and-so is my sports podiatrist. The questioner wants to know, is there really such a thing as a sports podiatrist thing? Is that a thing or is that marketing?
Well, that's a great question. There are podiatrists who have considerable knowledge about sports medicine, and particularly in the various shoeing and orthotics that are beneficial to specific sports. So yes, there is some degree of marketing there, and there's some degree of hoopla and bravado, but there are a good number of people who do have credentials in it. There is the American Academy of Podiatric Sports Medicine. So if you're looking, that might be a credential to check for. There is no specific board fellowship or board certification in podiatric sports medicine, but there are a number of people who do have considerable knowledge in that area. A good question, and I would wonder who paid for that sports shirt.
I think the intimation of the article was that the podiatrist gave it out for advertising for people to wear while running in the race. You know,
yeah, I would bet money on that.
You talked about when you were a kid, you bought a pair of Keds, or maybe Converse. The questioner writes, listen, when I was young, my mother would take me to a shoe store, and there was a shoe salesman who waited on us, and I would, quote, be fitted for shoes. Nowadays, if I go to a store, there's stacks and stacks of them, and it's kind of a do-it-yourself shopping experience. Or there's some teenager there who's working in the shoe department who doesn't know more about it than I do. Or I'm buying the shoes online. How does anybody know if the shoes fit anymore? Isn't this an era which is long past about anybody actually being fit for shoes or running shoes? You know?
Well, again, where you have 25, 30, 40 different brands that are there, the fact of the matter is many of them, if not most of them, will be okay for you. A lot of it depends upon style, what you like. A lot of these things have to do with color schemes and the laces and lights, etc. For the average runner, pretty much most shoes will do it. As you get up into elite running, if you're running more than 15 miles a week per se, then that starts to get significant running. In New York City, we tend to run on hard pavements as opposed to tracks and softer surfaces. So if you're doing more than 15 miles a week on a hard surface, chances are that you're going to want to have a shoe that's more akin to your foot. But for the average runner, as I mentioned in the talk, the key things that you're looking at is moderation. I'm not a big fan of the minimalist shoes. I think we see a lot of injuries, a lot of stress fractures with those shoes. The maximalist shoes, which have a high stack level, have very little proprioception with it, and your feet doesn't come into contact with the ground. We see an inordinate number of ankle sprains in runners who wear those shoes. So a moderate size heel, 4-foot flexibility, average weight should do it for the average runner. If someone has specific pathology, they have a cavus foot, a hypermobile flat foot, a significant equinus, they have neuromuscular disorders, then in those particular cases, they probably should consult a sports medicine, either a podiatrist or orthopedic foot and ankle person who has a little bit more expertise in those areas to recommend a more specific type shoe. And in some cases, they may be candidates to have an orthotic fitted to put into the shoe to control biomechanical abnormalities. But good question, and thank you for asking it.
Thank you. Marissa, the questioner writes, they notice that your guidelines talk about getting a second vaccine on top of a first vaccine, depending on which category you're in. The questioner wants to know, are there going to be side effects as a result of adding one vaccine on top of another?
Yeah, thank you. That's actually a really excellent question and brings up several points that I want to just touch on quickly. When we only had Pneumovax, the recommendation, it was recommended that you not receive a second Pneumovax sooner than 5 years later, even in immunosuppressed situations, not because of side effects, but because of decreased efficacy with multiple polysaccharide vaccines too close in sequence. The conjugate vaccines have posed a new issue. I didn't go into this in the talk, but the conjugate vaccines give you mucosal immunity at the, up here in your mucous membranes. And that's why when children were vaccinated with the conjugate vaccines, we saw this decrease even in adults because it decreased transmission tremendously. And when we started with Prevnar 7 and Prevnar 13, those serotypes quickly started to go away from the serotypes causing disease. So what happens with pneumococcal infection is you get what's called replacement serotypes. So you have very few of 7 and 13, and now you have to expand to 15 and 20 to get those other serotypes in. So the problem is trying to keep up with the organism, right? So I don't think it's an issue of side effects. It's an issue of decreased efficacy if they're too close in sequence. And those studies are still being done. But right now, the recommendation for 2 vaccines is only if you can't get 20. So if you can get Prevnar 20, it's 1 vaccine.
Tough to battle the forces of evolution.
Yeah, well, the organisms are always one step ahead of the pharmaceutical industry. You have to always remember that.
Thank you, Marissa. Dr. Murray, are you back with us?
Yes, Dr. Halperin, I'm here.
Okay, there you are.
Yeah.
Well, our questioners want to know what Dr. Murray's opinion is about prescribing birth control pills to a female minor if you sent the parents out of the room and they're in the waiting room.
So as
they're not trying to make it easy on you here, Karen.
No, that's okay. This is something that we deal with a lot, quite a bit. And as a physician, my obligation is to my patient. The patient is the young adult. And so that's who my obligation is to that patient. What we do try to do with our young patients is to explain to them about the confidentiality of their visit and that there are some limitations to the confidentiality of their visit, such as, if they're still on mom and dad's insurance. So certain things will show up on the insurance report. And so for that reason, we try to talk to our patients and have them as a part of the assent versus consent, assent, where they're taking part in their own decision-making based on their developmental stage. And so we do encourage them to speak with their parents. And sometimes we'll even, with the assent of the young individual, invite the parents in later on after we've completed the visit to have a part of this discussion. So I have no problem giving them birth control if that's what they require or need.
But making them understand that if they try to pay for it with the insurance, that eventually mom and dad are going to notice something on the bill, right?
Yes. I mean, I've had a patient who dealt with that same issue and ended up paying out of pocket for that reason. Yeah.
Let's have the last question, a rather sensitive one, Karen. What happens if the obstetrician gynecologist has reasonable cause to think there's sexual abuse going on of a teenager? The questioner wants to be walked through the steps of what actually happens.
Sure, absolutely. And it's not just the OBGYN. This most medical doctors are mandated reporters. We are mandated reporters. And in New York State, if you suspect that there is any kind of sexual abuse, you're mandated by New York State to call 311 if you live in New York City. If you live in other parts of the state, there's an 800 number for you to call the mandated reporter hotline directly. If you feel that the child is in immediate danger, then you would call 911. Once you've made this oral call, you are then required to submit a written report to the mandated reporter registry in New York State within 48 hours. Once that report is submitted, it is reviewed, and then they decide whether or not to get ACS involved. So it's actually a requirement. It's not just if you suspect abuse, you're required to report it.
Thank you, Dr. Murray. The
Mhm.
time has flown by. It is 2 o'clock Eastern Time. I want to thank all of our panelists for their presentations and for responding to questions. I want to thank everyone for joining us this afternoon. And we will see you next time. Probably our next broadcast will be during the fall semester. Until then, have a good rest of the summer. And thanks for joining us at this New York Medical College, Touro University webinar, 90 Minutes, the Medical Magazine of the Web. Have a good afternoon, everyone.